So good afternoon, everyone, and thank you for joining us today in this breakout on the impact of COVID and mental health on BAME communities. My name is Darren Fernandez, and I'm the Associate Director of Transformation at South West London and St George's Mental Health Trust. And I'll be co-hosting today along with Anna Babbage, who is our Communications Manager. So I'm really pleased you're here with us today to continue the conversations, and not only the conversations, to have discussions about some of the work that's ongoing and needs to be done going forward. But before I introduce our panel, I just want to run through a couple of logistics. So first of all, we will be recording the session, so all the information is captured and other people will be able to use this information and do it going forward. And secondly, your microphones will remain muted, but if you would like to, or if you choose to, you can keep your cameras on. We do, however, want this interactive session, a question and answer session for our panel. So please send your questions and comments in the chat function, and we'll do our best to answer as many questions to the panel as possible. But be assured, if your question is not answered, we would have noted it and captured that information. Ranjit mentioned the format. We have one of our panel members, Reverend Belamo Alagoa, sharing their experiences with us, and then we'll have the open Q&A session with our panelists. Can I ask our panel members to keep their cameras on with their audio turned off, and only turn their audios on when they're answering questions. This stops some of the echo effects. With no further ado, I'm going to ask the panelists to introduce themselves, where they work, what they do, after I mention your name. So if I could just start with Malik Gul, could you just introduce yourself, please?
Hi, hello everybody. My name is Malik Gul. I'm the director of the Wandsworth Community Empowerment Network. We've been in Wandsworth for, gosh, 20 years almost, voluntary community faith sector groups, working in partnership with the Mental Health Trust on a number of corporate initiatives, and specifically around the MHIP project, Ethnicity and Mental Health Improvement Project, with Professor Sashid Harun.
Thank you. Reverend Belamo Alagoa, could you introduce yourself?
Hello, my name is Belamo Alagoa. I'm one of the priests at Merton Priory Team Ministry in South Womb Building. And our parish is a part of Merton Citizens.
Welcome. Dr. Victoria Hill?
Hello, I'm Dr. Victoria Hill. I'm the Clinical Director for our Adult Community Services and Acting Clinical Director for our Cognition and Mental Health and Ageing Services at South West London St George's.
Thank you. Professor Sashi Sasharandan?
Hi, good afternoon, everybody. Nice to be here. My name is Sashi Sashidharan. I am a psychiatrist by background and also an academic attached to University of Glasgow. I have been involved with the Ethnicity and Mental Health Improvement Project at South West London St George's Mental Health Trust since last year. And this is a collaborative project involving the Wandsworth Community Empowerment Network. I am the external consultant to the project and actively involved in trying to bring about some significant changes in the mental health care for people from Black and minority ethnic communities in South West London.
Great, thank you. Dr. Iona Liddington?
Hello, I'm Iona Liddington. I'm Director of Public Health at Kingston Council. I'm delighted to be here this session this afternoon. I am part of the Health and Wellbeing Board for Kingston, of the Trailblazer for Young People's Mental Health, and our mental health strategy across Kingston, which was co-produced. So delighted to be here. Thank you.
Welcome. And finally, Dr. Ranti Laomi.
Hello, I'm really happy to be here. My name is Ranti Laomi, and I'm a psychologist by background. I'm also the chairperson for our BAME network at the South West London and St George's Hospital Trust, Springfield Hospital. And it's really lovely to be here today.
Welcome, Ranti. Thank you all. Reverend Belemo Alagoa has kindly agreed their experiences with us. So thank you for being here, Belemo. Can I hand over to you?
Right, okay. Like I said, my name is Belemo Alagoa. My experiences during COVID, when suddenly in March, we had the lockdown and we are locked out of our churches. It had a profound effect on me, in the sense that, one, I live outside my parish, so I was very, very disconnected. And it meant most of the contact that I had with my colleagues was through, either telephone call, email, or Zoom. And that was a bit difficult. And during the same time, we were working because we had to provide some kind of connection with our communities. So we decided to, to record voices. So that meant I did everything on my own, and suddenly, I'm finding myself to record my service on video. I was very glad that my older daughter still lives at home with me. So that made my life a lot more easier. So there's someone who can record me while I did the talking. That was very difficult because I've never done it like that, speak in front of, a lot of people. That is a recorded message to people I am not familiar with. So anytime I have to record my message, there's this anxiety. Am I able to do it? I felt that way. And with having to do that, and the other thing, I have to do most of the shopping at home. And I found that the COVID affected me like everybody else. The one thing that makes us very human, touch. I can't touch anybody. There's this fear when you go out that, whenever I go shopping, that something is going to happen to me until I get back home. And I found that very, very difficult to deal with. And in the midst of that, I am still, I'm expected to engage with members of my parish to be, and that will give them that support, either on the telephone or via email. Well, I managed to do most of that, but with a big struggle, that I was able to do that. And as we're slowly getting out of lockdown, my first and next anxiety was, how would I feel when I go back into church? How do I get others to come back into? Now we go back to church, and everything is different. The way we sit is different. What you do is different. So I am still dealing with the changes which have been so rapid. I mean, if we think about it, it's only a few weeks where 1 minute we could do everything, the next minute you couldn't do everything, So that's how, in some ways, it has affected me. And, family life was a big struggle too, having to teach my younger daughter, who has a disability. College has sent things, as I'm struggling to do my, priestly work, I'm also struggling as a parent to teach her at home. So I found these two, things, there's a tension in trying to be that. And it's almost like I am lost in between. That's the way I felt. I am lost. Almost, my name have disappeared. It's either I am mom, I am priest. So Belemon doesn't exist anymore. And, in a way, I am glad that there's some kind of semblance of, order, or coming back to something that is familiar, i.e. a good church. But there is still that's anxiety and fear, especially knowing that there is, as a Black person, I am more, prone to, COVID-19. So that has brought this additional anxiety. Into church, I am still behaving, like somebody who is, well, I'm very frightened. I go in, I kind of be brave to go into church, but I am anxious at the same time. My face doesn't show it, but really within inside me, I am very, very anxious. And I don't know how with, what is going on now, how much support locally that we can get. I know as a priest, there are some support that the Church of England has provided, but if it's still doing everything inside, it's on the telephone or is Zoom, and having to do everything on Zoom, it's also for me an anxious activity. So I'm not too comfortable with it, but it's like you just have to do, because that's the only way that you can communicate with people. So even being in this, today, it's very troubling and anxious for me. I hope that, some of my anxiety will be quelled by being part of it, as we look forward to the future.
Thank you so much for
now. Yeah, thank you.
Thank you so much for sharing your story. Okay, we're going to move on to some of the questions now to the panel, and please do keep your questions coming in the chat function. So Anna, can I ask what our first question is that we have?
So the one that's been sent earlier. What do you think is the impact of COVID-19 going to be?
So can I go to Malik first? What do you think the impact of COVID-19 is going to be on BAME communities, children, young people?
Thank you, Darren. Thank you. I think if I could just start off by saying that for me, one of the big surprises over the last 3 or 4 months has been how much people are actually surprised about how BME inequality, BME community active, because that shouldn't be a surprise. We know that BME communities over the last 20, 30, 40 years have suffered disproportionately in terms of disease, illness, social disadvantage, and so on and so forth. So anybody who had an understanding of how BME communities are marginalized and disproportionately impacted should have been aware that when a pandemic is going to hit, those who are poorest, living in the poorest areas, were going to be impacted. So that's just one thing I just wanted to kick off by saying, that actually inequalities, disproportionality, marginalization is a pre-COVID condition and a situation. COVID has just exemplified it and brought it out into the light in a very kind of deadly way. In terms of the question itself, I suppose from a BME perspective, there's a lot of fear of the unknown. There seems to be an institutional narrative that we've supported these, we've gone out, we've delivered services, and so on and so forth. And while on the whole that is correct, there's a lot of communities who have been disengaged, marginalized, not knowing what we should wear, what we shouldn't wear, can we go out, can we not go out, where can we get food, financial hardship. I have to say, from my own experience of speaking to community leaders, has been one of the biggest impacts on our community. Our communities are more than likely to be in precarious employment, are more than likely to be in low paid involvement, are more than likely to be in leisure industry, retail industry. So therefore, when the pandemic struck, and a lot of them who are already on low income, then forced to live on an even meager existence, the lack of financial support, financial advice, financial help has been one of the biggest impact on the poorest communities. And I suppose the discretionary funds that were available are not stretching that far. Universal credit remained very limited. Refugee communities, asylum seeking communities, those who have no access to public recourse, a lot of these communities have, for want of a better term, been left behind in terms of the official response. I think that the fear and the anxiety that causes, I just want to say finally, Darren, Black Lives Matter, very, very important movement that was triggered at the same time, that also created a lot of anxiety, because BME communities who have already been disproportionately impacted, when all of their stories and they were being amplified internationally, not only here, particularly in America, that brought home to a lot of BME communities the exact context in which they live in. COVID has just added to what's gone on, and that Black Lives Matter movement and the context has created further anxiety on our communities that needs to be addressed.
Thank you, Malik. Dr. Iona Linton, is there anything from a public health perspective you might want to mention?
So I think Malik's articulated well the sort of the lens that has been exacerbated rather by COVID-19 of inequalities. So people experiencing inequalities have been disproportionately affected. And we know that with that, when we're looking at what we need to do next and looking forward and learning lessons, we have to recognise that and build that into our plans for recovery, restoration and moving forward. And I think we're only beginning to see the economic impact of COVID-19. So while we've had this acute phase that Malik's articulated, the number of people registering or trying to register for universal credit has gone up. And we know that lack of employment, in housing and rent and people getting rent arrears will all impact on health too. So I think when we're looking at building plans together and working in partnership across health and care and councils and the voluntary and faith sector, we need to be all pulling in the same direction to make sure we're making the biggest difference. But we absolutely need to have plans in place, and we need to make sure that we have targeted intervention support for those that are most affected, be it from mental health, but also knowing that the economic impact will increase people's mental health vulnerabilities.
Thank you, Iona. Victoria, is there any kind of thing you might want to mention around the increase or impact in services you've been seeing within mental health trust? From communities?
Yes, Darren, yeah. I think I just want to second, what Malik has said. All of the inequalities that face, from the BAME population, which makes people more vulnerable to mental health issues, has just been exacerbated significantly by COVID. So although of the lockdown, we saw a reduction in our referral rate, I think as everybody kind of to a sort of a slight state of what we've now seen is the start of a surge of mental health problems and more referrals coming to the trust. And we are seeing a number of people, and obviously what we've concerned for me and the community services is reaching out to those hard to reach groups. And it's the work that we need to do, not just within the trust, obviously in partnership with our community services, our community supports, our ethnic minority support groups out there, to actually try and reach out to people who perhaps find it harder to access our services.
Thank you, Victoria. Is there anyone on the panel who want to add anything to that before we move on to the next question?
Darren, can I just add to that?
Sure.
Because I think Victoria is absolutely right. One of the things that to me a great deal is a lot of our organizations, networks, mosques, temples, churches, social networks, community associations, we already know who they are. This shouldn't be new news to us. Professor Sashi later on might want to talk about the EMIT project. I know Stephen's here from Merton and elsewhere. We already know who our churches, mosques, temples, community groups are. We already know the leadership of these organizations if we just care to venture out and speak to them. We already know the assets and the capabilities that they have. We already know the connections they have, the relationships they have, the social capital that they possess. One of the things that has often frustrated me is that we're still in a position where we're talking about who do we need to speak to, how do we need to engage with them, when what we need to do is bring them into a loop with us, invest in them and operationalize them to unlock their capabilities. I'm constantly frustrated about where is our Muslim communities? How do we work with them? Where is our Black church communities? How do we work with them? Where is our marginalized communities? How do we work with them? These are the known knowns. We already know who they are. We walk past them on the street. We eat with them in restaurants. We know who these community leaders are. What we haven't been able to do is bring them into a co-produced relation with us. We've often patronized them, invited them to summits every now and again, once every 6 months, but we haven't invested in unlock their capabilities to be co-producers. By now, we should be able to do that. And I think that's one of the things we need to do forward, to move beyond, let's just have a conversation, let's just listen more, let's just hear more. We need to move beyond that and into operationalizing and unlocking social, because we know how to do it. So we should do it.
Thank you, Mike. Dr. Ranti, is there anything you might want to add from a staff's perspective? I know Malik's mentioned around empowering and supporting people, and we know who people in our community leaders are and how we can perhaps work differently or should be working differently. From a staff perspective, I suppose, is there a way we should be doing more to empower our staff to do things differently, be working in different ways?
Yes. Thank you. Thanks, Darren. Thanks, everybody. It's been well covered by everybody, but there's just a couple of things that I'd like to add. I think a lot of the things that we grew up with will be an implicit bias of the other. And we already know, we've grown up in a society that's already prejudiced, and we have been a part of that growing up. I mean, if you ask most BAME people, there will be a number of questions that they've had to either field or refuse or just politely put to one side, like, so is that hair real, or your hair's really bubbly? Things that make you feel really different to the other. Now, what COVID-19 has done is it's almost thrown a spotlight on the kind of differences we've grown up with that were not really looked at, the kind of stresses that you grow up with, even if you're in a good job at the moment. So between March and April, all the doctors who died in A&E, 9% of them were from BAME communities. This is a terrible statistic. These are the breadwinners of their families. They are important people in their communities, and this impacts not just their families, but it ripples into the communities that they live in. So one of the things that we noticed is that in staff groups who are from BAME communities, there is a huge anxiety to come back to work and do face-to-face work. Happy to work 24/7 behind a computer, but every single person, they're more likely to catch COVID and die from COVID. As a result of this, they're reluctant to come back to work and do face-to-face work. Now, this has a knock-on effect on people's psychological well-being, the kind of isolation that the Reverend has spoken about, the kind of losses that you've had in your community, because most people know one or two people who have died. The difficulty, the anxiety you feel about re-engaging with society, the kind of fear of job losses or somebody who is your breadwinner dying. All these things are things that feed into the staff net, and it impacts the kind of face-to-face care that we give. I don't think I want to add more because I think there's a lot to cover. However, we need to just address more questions.
Thank you, Ranti. Shall we move to the next question, Anna?
Yes.
Please.
So the chat's getting very busy. Priya is asking at what point the organization will automatically provide advice and guidance that is translated into other languages which our communities speak, and what will ensure a health organization to take this approach?
Yeah.
Okay. So, Iona, I might go to you first, if I may.
Yes, so my understanding, certainly from a Kingston's perspective, but also there's been work across London, that all of the materials initially around sort of catch it, bin it, kill it messages, the hand washing messages were translated into the main languages. I know Doctors of the World similarly have been offering that service, and those materials are shared both with the GLA as well as with local councils. So for us in Kingston, we produced it in the 5 main community languages, but the Doctors of the World material, I think, were available in nearly 200 languages. And that's the same for the test and trace information. So how to book a coronavirus test, the symptoms to look out for. In terms of knowing whether it's been translated into British Sign Language, I don't know that for sure, I'm afraid. I can find out and let you know, but at the moment I can't actually answer that question just now. But clearly there is an important a community engagement piece, as well as having written materials. It's actually using our community groups, those networks that, again, Malik was referencing, because they're trusted sources in populations, in communities. Those community groups, faith leaders, those points of contact are really important in people's lives, and getting that information out to them. So we don't want to just rely on printed materials or digital materials, but using also that community outreach approach so that we're getting those messages out to everybody. And I think research from other parts of the country where they've seen, sort of negative impact, actually using those community resources have had one of the best benefits.
Great, thank you, Iona. Just building on that, I know that there's lots of pockets of really good community work, working with the Mental Health Trust and the council happening across different boroughs and at different rates. How do you think that should be changed or done a bit more mainstream or more differently? Because I think things are happening at different paces, different speeds, and it depending on the kind of dynamics in different boroughs. But actually, how do you think maybe we should have a much more standardized approach to this is the way we kind of do things with our communities, and our communities do things with us?
I think it's trying to learn the best of both, really, so that where we can do something well once and share it, then we absolutely should do that over bigger geographies. But then other parts are reliant on those local relationships. So it's using a blended model. So I think if areas have produced materials in different community languages, then to share it. Because whilst it is only a small amount of money to translate materials, as soon as they're produced, we should be sharing them out across London. It really isn't too difficult to do that, but our local communities will potentially have different apps that they're using. I think it depends also on things like the social prescribing sort of model that's in different boroughs. So being able to change messages to online and home-based, so keeping mentally well when at home, physically well, sleeping well, all of those sorts of messages. We could get the core information correct, how it's used in each of the boroughs, again shared for it to go on to its own platforms for social prescribing. Because I think certainly that seems to have strength across communities, using a sort of social prescribing model but in an online way.
Thank you.
And Darren, there's a just follow-up question from Lenka. If those translations included British Sign Language?
Yes, I said I wasn't sure that they had. I think Croydon were producing materials that were shared. So I don't know how widely they've been used, but there were some materials. I don't know exactly the content, I'm afraid, but I know that has been taken into account, and Croydon led as on that.
Great, thank you. Professor Sashi, to you. Is there would you want to add any comments to the discussion on this at this point? Or engage with the community?
I don't have any specific observation to make in terms of what's happening locally, availability of material and sharing information and the services. But I do want to make a more general point arising out of the work that I'm involved in. And that is to say that COVID has done is to remind us of a very old problem. That is something to do with ethnic race inequalities in our services. As Malik has said, as Ranti has marked, dealing with two epidemics. The pandemic of COVID is a new epidemic, but there is another pervasive epidemic that's been silent or unseen for a long time, and that is to do with racism, impact on our institutions and the way services are being organized and how particular groups of people are being not just disadvantaged, but put at risk way institutions respond to their needs, particularly their mental health needs. And what COVID has done, in one sense, is made that more visible. And this is something that we should not write off, because we have been through not dissimilar situations in the past when the program of austerity hit us across the country. The problems had a particular or disproportionate impact on people from minority ethnic groups. And these challenges became evident. People talked about it, identified it, highlighted them, but very quickly that focus shifted on to other things. And again with COVID, we are made aware of the disproportionate impact on most marginalized communities in this country. There is a risk when the peak of COVID passes, the focus of our attention might shift on to other things. That's partly because it has historically been much more difficult to challenge this more pervasive epidemic of racism and racial discrimination. And what we really need to do is to actually commit ourselves to challenging and changing that in our organizations, in our communities, in a meaningful, practical way. And the project that I'm involved in with Southwest London St. George's Mental Health Trust and Wandsworth Community Empowerment Network is precisely the kind of approach that we will need to expand across all communities. This is an attempt to try and reduce ethnic inequalities in service access, service experience, and service outcomes in mental health care in Southwest London. And this project started before it hit us. What COVID is reminding us is the absolute significance, importance of being able to push through that project and similar projects. One final observation. What COVID has done to BME communities and across all communities is that it has imposed mental health burdens, additional burdens on us. Partly because our social selves, the aspect of us that is nourished by interaction with other people, the social side of ourselves has been put into lockdown as a result of lockdown. Our social cells become or at risk of becoming atrophied, being compromised as a result of that. And the importance of establishing communications with other people, coming together as a way of addressing that problem is very significant. Otherwise, as people have said today, problems with anxiety, problems with depression, mental health problems will increase. The answer to that is to animate that social self and to make it available so that we can make connections with other people. And the downside of this is that people with significant severe mental health problems are particularly at risk of experiencing multiple problems as a result of this enforced social isolation, enforced exclusion from society. And we've got to be aware of that. Positive side, what I have seen, I have been through several webinars of this kind, talking about how communities are responding to it. What's most exciting to see is how our social body has been animated. People coming together, like in this webinar, from different and speaking with one purpose. We are out of our silos in meetings like this. COVID has made that possible for us to think about a common purpose in addressing not just COVID, all the other problems that have been revealed by COVID, including discrimination, inequality, how we can improve our services to address those.
Great, thank you, Sashi. So there's something about, as you say, that the inequalities have been existing for years, and the health inequalities, and actually doing something a lot more practical and operational around making those significant changes. Yeah. Thank you, Sashi. Ranti, did you?
Yes, I would like to just add to what Sashi has just said. I think one thing that I think we do and do well at Greenfield is that we do engage with the communities, and this is something that I think we would need to continue, but maybe continue on a larger scale, because contentious topic, I know, not everybody reads and writes as well as we may imagine that they do. And even if they read and write well, maybe they're not reading and writing English as well as we think they are. So we need to engage with those communities, maybe faith communities, maybe just empowering networks that are very community, culturally based in and around the area, who talk about things to do with other people, but in different languages. Those communities can have it translated for them or just spoken to them, rather than, I mean, leaflets are great, don't get me wrong, but sometimes you need somebody to actually speak language and tell you just in a few words what you need to do, how you need to do it. And those, especially women, those women are key in getting messages to other people, older women, and maybe children in the communities. So just to add to that, I know we're running short of time.
Yes, thank you, Ranti. Just to say to everyone, we will be going back to the main room in the next minute. I'm sorry that we haven't been able to answer all your questions, but we have noted all of them. And just to say thank you to all of our panel members as well. Thank you for coming along and talking to us and sharing with us your thoughts and views. You will, at the end of, in the next 60 seconds, get a list on your screen to say leave the breakout room. When you click on that, you will be taken back to the main room where there's going to be a plenary session and a tying up of the session as a whole. So just thank you and to all of you, and we've got all your comments as well and your notes, and we will see you in the main room. Thank you, everyone.
Thank you.
Thank you, Darren.